right, good morning, everybody. Did everybody get access to the donuts? How cool is that? So my job today, first of all, are there any questions from last time that I can answer that you want to ask publicly? Okay. If nothing, know that I'm available by email or I'll be here for the rest of this week. Yay! Yay! So good morning. I'm so glad you guys decided to come in and join me in class today because it's rainy out and it was really, really hard to get moving this morning. So thank you for showing up so that I wasn't talking to an empty room. And today, my job is to talk to you about clinical use of glucocorticoids. So I have two lectures for this. The structure in this class has stayed the same since I started teaching it, I don't know, like 20 years ago. But, and they've always had like two lectures for this, which I feel like we need some on glucocorticoids, but the other drug repertoire has expanded a little bit. So I'm going to talk about glucocorticoids during this lecture, and then the next lecture we're going to do some cases. And we're going to talk about using some of these drugs and also using some of the other drugs that we've talked about, some of the adrenal-lytic drugs that we've talked about. So we'll do that tomorrow. We'll talk about those. I'm going to tell you right now what I want you to know from this lecture. The most important thing to know from this lecture is, we'll get to it at the end, but I'm telling you now so you know that when you have to wake back up again, is that there are different uses of glucocorticoids depending on the dose that you use. We talk about them in a prednisone dose. And these are things that there are a lot of things that you don't really need to know that you can kind of look up or don't really need to have at kind of the tip of your tongue. But this is walking around knowledge that you really need to have. So we're going to talk about the different types of uses for glucocorticoids, and then we're going to talk about the doses and prednisone doses that we're going to use. And I can tell you that is what I will test you on for the material for this lecture. And we will go through some clinical examples of using glucocorticoids the next lecture. This absolutely is the most critical thing I think you can learn from this lecture, and probably from all the lectures that I do. I can't tell you how many times I've seen cases come into the hospital that have had to get referred in because people have not known how to use glucocorticoids correctly and have overdosed animals on glucocorticoids and caused lots of problems. So that's the really important thing that hopefully you will get from these lectures. But as always, the foundation of good medicine is a good understanding of physiology. So I'll just do a little brief physiology on the areas that we're talking about. This is the adrenal glands. So we already talked about it last week, but I know between now and then you've had like a ton of different things in your head. So we'll just review the physiology a little bit. And we're going to talk a little bit about structure and function because this is a pharmacology class. You will never have to know what the structure of these drugs look like, ever. But it's good if you sort of have an understanding of it. I certainly won't ask you about where a methyl group goes or anything like that. Because you won't need to know that, but it's kind of good to understand how the drugs are a little bit different. So we'll talk about that briefly. We're going to spend some time on the different forms of glucocorticoids that you can use, and then the dosing rules for clinical use, which again, as I said, is like walking around knowledge that you need to have as a doctor. Okay, so we talked about this last Friday. About the physiology of the adrenal cortex and what's important about it. Remember that all of your glucocorticoid and mineralocorticoids are synthesized in the adrenal cortex. Remember, the medulla secretes your catecholamines. And remember that the really exciting thing about that is that depending on what layer you end up in, there's a different enzyme there that will make a different hormone for you. Again, that's important, and I like to think about that all the time because when you see an adrenal tumor that presents to you, it could be making just about anything. Half the stuff we can't, well, probably 99% of it we can't measure, but it's going to be, so it can do all kinds of weird things. So glucocorticoids actually are a significant amount of the hormones that are produced in the adrenal cortex. And that's kind of interesting too, because we can look at adrenal size to estimate diseases of the adrenal gland. So for instance, if you have hyperadrenocorticism or Cushing's disease, your adrenal glands will actually get bigger, versus if you have hypoadrenocorticism or Addison's disease, your adrenal glands actually get smaller. And so that tells you how important those glucocorticoid production is in the adrenal gland cortex, because it gets bigger or smaller, and as it does that, that can reflect the amount of glucocorticoids that you're secreting. So cortisol or hydrocortisone is the most common natural glucocorticoid in the cat, horse, pig, sheep, and human. Okay. So glucocorticoids got named because of their effect on glucose regulation. So this is a huge thing that I find as someone who spends a lot of time trying to treat diabetes mellitus. Glucocorticoids can have a huge effect on that. And that's actually, again, where they got their names, because glucocorticoids interfere with insulin. And so it interferes with the ability of insulin to do their job. And I'm going to remind you again of this adrenal axis. You're going to be seeing this a lot in, especially the adrenal gland, because we use so much of it in testing for adrenal gland diseases. We talked about this last time, but I'll just remind you that it is the hypothalamic pituitary adrenal axis. Cortico-releasing hormone gets secreted by the hypothalamus. ACTH gets secreted by the anterior pituitary, and that directs cortisol release from the adrenal glands. And what's the most important part of an endocrine axis? That's going to be your negative feedback. You are set to turn off. No matter what hormone you're secreting, your body wants to turn it off. So those are really powerful. We can take advantage of these all the time when we're testing for adrenal gland dysfunction. So we're going to be using things like an ACTH stim test, which we talked about a little bit last time, to actually stimulate the adrenal glands and see what we can get from them. But even diagnostically more important is we're going to use things like a suppression test where we give them a lot of cortisol to see if we can shut this system off. Again, taking advantage of this negative feedback. Okay. The cortisol is secreted episodically. This is a problem for us in terms of using cortisol measurements to diagnose adrenal gland diseases. We do use baseline cortisol. It is helpful, but it is not as helpful as, let's say, for instance, thyroid hormones. Those are really important. We can get a lot of information from baseline thyroid hormone measurement, which we don't get from cortisol because it's secreted episodically. In people, you have a diurnal rhythm. So you'll secrete more cortisol at certain times of the day. We don't see that in animals. It tends to just be episodic. The other thing to remember, we talked about this last time, is glucocorticoids affect almost every cell in the body. So again, the reason that's important for you as doctors is that if you see a disease where you secrete too much, or if you supplement glucocorticoids, you're going to see a ton of clinical signs because they're affecting lots of the body, and vice versa. If you don't have enough, you're going to be seeing a lot of clinical signs. The other advantage is guess what? We can use these pharmacologically to help us treat diseases. So you can use them for a ton of diseases because they help a ton of things in the body. All right, so some of the ways that we use glucocorticoids. We use them for their anti-inflammatory, oh, I can just look over here. Anti-inflammatory, and I have to like crane my neck up there. Anti-inflammatory and immunosuppressive properties. So they have a ton of ways to stop the inflammatory process. Who has used glucocorticoids to help with inflammation? Okay, how many runners are in the room? Oh no, come on, really? No? Is anyone running the half? The Athens Half Marathon? Oh, come on, guys. Yeah, somebody's got to be running it. Come on, someone's got to be running it out there. Are you running it? Good. Well, you'll probably be way faster than me, so. Well, then come out and cheer us on. around mile 10, we go up this horrible hill right by the vet school over here, and they need lots of people like yelling because it's really bad. Anyway, if you are a runner, and most of you have probably been athletes in high school and college, you're going to be very familiar with the anti-inflammatory effects of glucocorticoids. My husband, who likes to ride his bike a lot, he got into, I don't know, we were on this trip and he got like this rash that broke out, so I told the pharmacy he was my dog and I got him a whole bunch of prednisone. And I didn't do that, but he was so excited. He goes, oh my gosh, this is great. Like his rash went away, right? But then all those little aches and pains that you get when you're an older man and you ride your bike a lot went away too. So it's a very powerful anti-inflammatory agent, and we use it all the time for that in many, 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 many different forms. So it downregulates a lot of pro-inflammatory proteins. I've listed some of the ones up there that are very common pro-inflammatory proteins. Not important that you remember them at this point because honestly they change like every 2 years. Someone finds a new cytokine that's more important than the old one. But they downregulate a lot of the pro-inflammatory proteins, and they upregulate the expression of anti-inflammatory proteins, okay? So lots of ways they work that way. They have a lot of cellular effects, and this is a way that we see them help us when we're trying to treat diseases when we use them, but it also is one of the ways that can actually cause us problems. So they cause decreased margination of neutrophils. So what's a bad side effect of that, can you think of? So a bad side effect of that, so let's say you're using them for an anti-inflammatory process, but they're going to decrease your margination of neutrophils. That means that you're not going to be able to fight an infection, which may be what you're wanting to do with these drugs, but you have to remember that if you're using them, and let's say the animal's got like a brewing pneumonia and you don't know about it, and you use these drugs to treat something like an anti-inflammatory process, you have to be really concerned that now you've immunosuppressed this animal because you've marginated the neutrophils. The other thing is, you guys have had ClinPath already, right? Are you taking it? Oh, you haven't had it yet. Okay. Well, one of the things that you'll learn in ClinPath is because you decrease the margination of your neutrophils, when you use glucocorticoids, or if you have a disease like Cushing's disease, where you have too many glucocorticoids, you're going to see an increase in, you're going to see a neutrophilia, okay? And that doesn't necessarily mean anything except that you're under the influence of glucocorticoids. Okay. You're going to decrease your monocyte and macrophage function, all right? So those help gobble up a lot of bad stuff in your body. You're going to decrease that. You are going to suppress lymphocyte proliferation and function. Can anybody think of something good that would do for you? Get rid of lymphocytes. Does anybody have golden retrievers? What is the disease you worry about the most in your Goldie? Cancer, right. And what do they get? Lymphoma, right. So can anybody think of a reason why you might use glucocorticoids to help you with Goldie that has lymphoma? Yeah, you can kill those bad lymphocytes, right? So it's lymphotoxic, okay? Also, you will learn this will be drummed into your head next semester when you have ClinPath, but you will see neutrophilia, lymphopenia, eosinopenia, and a monocytosis. That is characteristic of a stress leukogram. We see this and we can characterize this when an animal is ill and they're stressed, but we also see this when we give them glucocorticoids. And you also see this in animals that are cushingoid because they're under the influence of excess glucocorticoids. They stabilize lysosomal membranes. They inhibit fibroblast proliferation. This is a big deal for wound healing. So the soft tissue surgeons don't like to do surgery on animals that have a lot of glucocorticoids in their system because it inhibits healing. So if you had a cushingoid animal and you asked your soft tissue surgeon to do an adrenalectomy on that animal because you had an adrenal gland tumor, they would probably want you to get those glucocorticoids down lower, at a lower level so the animal would heal nicely afterwards. But we can also use glucocorticoids to help us with anti-inflammatory properties. Again, there's always good and bad stuff, right? But one of the ways that you might want to inhibit fibroblast production is let's say you have a, you're going to, I'm an internist because these are all the cases that I think about, but let's say that you have an esophageal stricture, right? So let's say that the owner lied to you and actually didn't fast their animal before they got it spayed, and you put it under anesthesia and it vomited during anesthesia, and all that nasty gastric juice got in the esophagus and caused a nice stricture. And then all of a sudden your animal can't swallow normally, so you bring it in here and I say, oh, we can balloon it, right? And we can open that back up again, but as soon as we do that, we're going to make that area mad. And so we want to prevent it from closing back up again and from the fibroblasts proliferating. So a really good way to do that is then to do some interlesional glucocorticoid therapy. Okay, so good and bad things for everything. With glucocorticoids, you can also inhibit mast cells and histamine. So if you have a horrible reaction, let's say to a vaccine, maybe you'll know that and you'll pre-treat with Benadryl or something like that. But if it sneaks up on you and you don't know about it, glucocorticoids will usually take care of the problem for you. Tons of vascular properties. You can increase your circulating red cells. Cushingoid animals may have an elevated packed cell volume because cortisol helps you kick out your red cells from the marrow. You can have an increase in circulating platelets. Again, cushingoid animals and an animal that's treated with lots of glucocorticoids can look the same as a cushingoid animal. You might have an elevated platelet count, one of your big differentials for excess platelets. You have reduced capillary permeability. These guys will tend to bruise more if you're using a lot of glucocorticoids, and it will actually enhance vasoconstriction and may cause hypertension. We do see some animals under the influence of a lot of glucocorticoids that are hypertensive, so it's something you need to worry about. Lots of metabolic effects of glucocorticoids. Like I said, they hit just about every cell in the body, so you see tons of favorable responses to glucocorticoids, but then tons of other effects that you may not anticipate. They antagonize the effect of insulin, okay? This is a biggie, and again, that's why they were named glucocorticoids, because they tended to cause an increase in glucose. So this is a big problem when you're trying to treat a diabetic and you have to give it an anti-inflammatory or an immunosuppressive dose of glucocorticoids. You will know that you're just going to have to increase its insulin. So they stimulate gluconeogenesis from the liver, and that's really because it inhibits insulin. They increase lipolysis. They cause muscle wasting. Has anybody heard the term Pred head? Okay, Pred head. So if you have a cushingoid animal, but really the ones that we really see it in are the ones that are on immunosuppressive doses of glucocorticoids for a disease that they have, so you're using it to help them, they will get this, they will get the atrophy of the muscles in their head, and they get this really pointy looking head because their little skull bone sticks out. So it's called Pred head, and that's because of severe muscle catabolism. You see increased fat and glycogen deposition in liver cells. So these guys is one of the things we see in cushingoid animals. Again, an animal that's treated with glucocorticoids can look the same way. They tend to get muscle wasting, so their flank muscles will deteriorate, and then they get a big pot belly because their liver gets so big because you have all this glycogen that's accumulated in the liver. They can inhibit the cortisol-stimulated alkaline phosphatase isoenzyme. That is in dogs only. That doesn't happen in anybody else but dogs. So you can see an elevated alk phos. You don't have to worry about horrible gallbladder disease or anything like that. I know you don't know about all these things yet, but you will. But you can blame the glucocorticoids for that. And they can inhibit bone formation. And they promote calciuresis, so we can use them to help us with hypercalcemia. They don't tend to cause bone fragility, at least in our animals for the most part, because I don't think they live as long. If they lived for 30 years under cortisol excess, we'd probably see something, but because we don't, they don't live that long. Even an untreated cushingoid animal doesn't usually get like bone fragility. Glucocorticoids potentiate the effect of catecholamines. Okay, so they're going to make your stress response worse. They increase the secretion of gastric acid, pepsin, and trypsin. This is big. If you overdose a dog with glucocorticoids, you can cause a really nasty gastrointestinal bleed. Okay? And they inhibit ADH action in the kidney, causing polyuria, polydipsia, a huge side effect of using glucocorticoids. So something that we need to be familiar with. They also alter mood and behavior. So has anybody ever heard of roid rage? Yes. Okay, it happens. It happens in dogs. I don't know if I've seen it. Cats are so resistant to glucocorticoid side effects. I've definitely seen it in dogs though, and I am sorry for all of you large animal people because I don't treat horses, so I can't really tell you like what happens. I don't know if birds get it or anything, but I do know that dogs get roid rage. We see that. Okay, so we have to talk a little bit of pharmacology. This is actually kind of cool too, just so that you understand how these drugs work and how they're related a little bit. So all of your steroid type and hormones, and this is one of the strengths of this system, of all of these glucocorticoid or adrenal or really steroid, no, that's not, yeah, steroid hormones, I guess you could say that across the board. They all have this very similar nucleus, and everything is kind of made off of this nucleus that comes from cholesterol. So you have cholesterol everywhere, everywhere. And so you have the precursors for these hormones all over the place. You don't have to eat iodine like you do when you make thyroid hormone or anything like that. The cholesterol is just sitting there. And so what you just need are activation of enzymes to make your mature hormones. And so they use this very common nucleus. And I'm sure that the clinical pharmacologists, the people that are really smart and make drugs, were like thrilled to have this because all they have to do is add stuff to it and they can change the way that they work. All right, so the synthetic glucocorticoids, and this makes sense, you're going to make a drug that's going to work the way that you want it to. Okay, so you're going to try to get rid of the points that you don't want the drug to have, and then enhance the properties that you do want it to have. So because we have this common nucleus that forms all of these steroid hormones, one of the things that pharmacologists were able to do is create a whole bunch of different synthetic compounds that would take advantage of the properties of the glucocorticoids that you want to take advantage of, and then decrease the properties that you don't. So these are some for instances, and again, I don't think it's that important that you memorize these. If you want to look them up, it's easily available in formularies. Do you all have access to VIN, right? Okay, so VIN has plums online, and you can look up anything in that formulary that you want. It'll go through pharmacology stuff for you. I have a table I'm going to show you I pulled right out of Plum, and it's right on there for you, and all of this is in a formulary. So you certainly don't need to memorize these, but it's nice to think about the way that they get changed to enhance or change their properties. So this is just a for instance. So if you unsaturate an area in one of these rings, then you're going to enhance your anti-inflammatory properties, and you're going to reduce your sodium retaining effect. So again, just an example of something you can do to make a drug for yourself that, again, is going to take advantage of your naturally occurring cortisone. You're going to change it a little bit to give you what you want to use pharmacologically. Another example of this is an introduction of a methyl group will actually change the way that you can, the way your mineralocorticoids work. So if you put a methyl group in here, that changes prednisone to dexamethasone with a little bit of an extra change, but it's this methyl group that really changes the side effects. And the thing is, if you know that, and you have an animal that's on prednisolone and is having horrible side effects of polyuria, polydipsia, you could say to yourself, wow, I wonder if I put it on like dexamethasone, if I could get rid of that. And that's one of the strategies that we use. We talked last time about supplementing addisonians with prednisone long term? Well, there are some animals and dogs that are especially prone to the polyuria, polydipsia side effects of prednisone. And sometimes you can't get them on the dose that's high enough to supplement their glucocorticoid activity without them getting the side effects of the prednisone. But if we put them on like a different drug like dexamethasone, we can give them what they need glucocorticoid-wise and then take away the side effects of the polyuria, polydipsia. Okay. Some of the other things that are important about synthetic glucocorticoids, again, remember you just add little things here and there and you can change the properties. Not really important that you remember that. We also know that pharmacologically, when you make drugs, you're going to want them to hang around. We're going to talk about this a little bit more when we talk about insulin therapy, because that's a biggie in insulin therapy. But synthetic glucocorticoids, as you might imagine, bind less to serum proteins, diffuse more readily. Of course they're going to, because that's what you want them to do. They have a greater affinity for steroid receptors. Again, that makes sense because you're going to want them to do that, because you're going to want them to work better. And they're degraded more slowly. Again, all the things that you would want them to do to make them drugs. So how do they work? Last time we talked about, I think we talked about, sorry, it was a different thing. Sorry about that. There are different ways that hormones work. You can be a peptide hormone, and you can bind to a cell surface receptor really quickly and activate that cell and work quickly, quick on, quick off, like insulin does. You can work that way. Or you can be a steroid type receptor or a thyroid hormone type receptor, and you are actually lipophilic. So you can travel through you have to travel through the bloodstream bound to a protein, but once you see a cell surface, you can actually go through that lipid bilayer, which is what these steroid hormones do. So they can go through the cell membrane, they get into the cytoplasm, they bind to cytoplasmic receptors, and then they actually have a protein that helps them bind to the regulatory areas so that they can actually cause DNA transcription protein. They make proteins. And so when you have these hormones that work, it's not like a peptide hormone that uses a cell surface receptor to usually kick off a bunch of enzymes. These hormones are going to work by actually synthesizing proteins. So they're going to be slower than peptide hormones. And their effects are going to last longer than peptide hormones, because basically you're making a protein and you have to wait for that protein to be degraded before the effects of that hormone go away. So the basic tenet of the whole thing is these guys are going to take a little bit longer to work, not all the time. They can work pretty quickly sometimes, but it's going to take a while for their effects to go away. So if you give a steroid or a glucocorticoid, it's not going to be a quick effect like you see with insulin, but the most important thing we see as doctors is it's going to take a while for the effects to go away. There are many, many synthetic glucocorticoids available, and we use them all over the place. You can use them in the eyes, the ears, you can use them intralesionally, you can use them obviously orally, intramuscularly, subcutaneously, intravenously. We can use them in a bunch of different ways. Depending on what they're mixed with, they're absorbed very, very well. The potency of glucocorticoids is assessed by the anti-inflammatory activity. That was just something somebody made up when they were talking about how potent they are, and it's compared to hydrocortisone, which is given a value of 1. That probably makes no sense to you, but this will. I pulled this right out of Plum. This is a really helpful chart. It is probably also in, have they talked to you about formularies yet in this class? Is that like the first lecture? That should be like the first lecture, but they didn't do that. Anyway, you will learn about formularies. Plum is a good one. The other one out there is Papich. People have their own favorite formularies, but these are all in there in terms of some sort of a table to help you decide what kind of a glucocorticoid you want to pick. So for instance, if you wanted an anti-inflammatory and let's say you were using prednisone and you didn't like the way that it was working in your patient, but you wanted to use a different drug that you think may have less side effects in your patient, but you wanted the same anti-inflammatory potency, you would have to use 4 times the amount of hydrocortisone to get there, okay? The big thing that we use, and this is, again, something I'm going to test you on, I promise, and we'll talk about it, so it won't be a surprise for you, is that we do a lot of switching between dexamethasone and prednisone. So there's like a 1 to, I mean, some people use 8, some people use 10, but there's basically a difference in your anti-inflammatory activity. And this is where people get into trouble when they switch back and forth. So you as a doctor will, let's say, have an animal that comes in that has an immune-mediated hemolytic anemia, and you know you're going to have to give that animal a lot of glucocorticoids. Or you have an animal that comes in that has one of those horrible pemphigus things that Dr. Ostel was talking about. Already you know, like, oh my God, I'm going to have to load this animal up on steroids. So you look up the dose in Plum, and it gives you a prednisolone dose, but you want to give something that's basically an injectable, and you want to use dexamethasone. You need to know in your head that you're going to have to reduce that dose by 8 to 10. And if you give the equivalent prednisone dose in a dexamethasone, especially IV, you could blow out that dog's stomach and cause a really horrible bleeding ulcer. So that's what I was saying as a doctor. There's just some walk-around knowledge that you need to know, and that's some of it in terms of converting glucocorticoids. But this, again, this is a table that's available in some form in every single formulary, so you don't need to memorize it. There's just a few key things you need to have as walking around knowledge. All right. Hydrocortisone, prednisone, and prednisolone have mineralocorticoid activity. Prednisone and prednisolone, and we tend not to use prednisolone in dogs as much because it's more expensive. We tend to use it in cats because they absorb it better and they have less side effects. But prednisone in dogs causing the side effects of polyuria and polydipsia can be a big problem. And so again, you may want to switch to a dexamethasone because it doesn't have mineralocorticoid activity and may not cause that side effect. Prednisolone and cortisone need to be activated by the liver to prednisolone and cortisol respectively before they're activated. That tend not to be a problem, except if you're in liver failure and you're not going to probably be using steroids on those animals anyway. We use prednisolone in cats because we feel like they absorb it better than prednisone. Okay. Okay, so we talked about what glucocorticoids do. We talked about some of the chemical changes that you can make to give you the pharmacologic activity that you want. We talked about relative potency. Again, hydrocortisone it was picked as a baseline with the anti-inflammatory activity of 1, and then everything was kind of compared to that. The other thing that we have to think about is what you can do to the structure of these molecules to, again, give them more pharmacological properties that you want to make them hang around longer, okay? Again, not really that important that you memorize this because this information's available to you in any kind of a formulary, and you will get a sense when you get into practice, like what you're gonna use when. Like, I'm gonna use this because it's gonna last longer. I'm gonna use this because it's gonna work fast and go away fast. You'll get a sense for that, but this is gonna be the basis on which those decisions will be made. So the duration of action is inherent to each synthetic glucocorticoid. And so they can synthesize these by putting stuff on them, like ester side compounds, that can make them be broken down then less rapidly, so they can hang around longer. So these are some examples here. Again, honestly, you certainly do not need to memorize these. Just know that this is some of the principles that we use to help us. Some of these drugs that we're going to talk about you'll probably recognize because you've used them in the practices that you've worked at. But these are just some examples of some of the things that you can put on the side of, remember, this is kind of our basic steroid nucleus here, and depending on whether you're going to put this on a dexamethasone or a prednisone or whatever you're starting out with your nucleotide, you can put something on here to then make it last longer. Okay, so if you have a highly soluble ester, it's going to release this compound more quickly when you inject it, okay? So these are going to be the drugs. Like, when would you use these drugs? Like, who's used Solu-Delta? Who's used Dex-SP? Somebody must have. Okay, when did you use it? Okay, vaccine reaction, okay? You want it to work fast or slow? Fast. All right, so great example of why you would pick that drug. It's got a really soluble ester. You're going to use it. It's going to go away fast, okay? So these are some of the examples of things that you can use. You've got prednisone compounds. You have hydrocortisone compounds. Again, these may have less side effects. You have methylprednisolone, and that's usually, we think about that because that's usually what we think about with Depomedrol, and that usually lasts a long time. But this has a sodium succinate side chain on it, which is going to be released really, really quickly, so that's a form that you could use really quickly. I will say the one that you're probably going to use the most is either Azium, which is dexamethasone, just trade named, or dexamethasone SP. These work really, really quickly. We use them a lot in emergency situations. And again, it also comes in a sodium succinate. You can use hydrocortisone and prednisone, like Solu or Solu-Delta-Cortef. Again, quick working. Whatever practice you get into, you're probably going to have one of these emergency acting steroids on the shelf, and that's what you're going to use. My guess is it'll be Dex-SP because it's the cheapest one out there. All right, if you decide to put propylene glycol on your glucocorticoid, it's going to last longer, okay? So when you inject it, again, it's just going to be like more of a timed release because it's going to take longer for this to dissociate off. So minutes or hours it's going to take for you to get these off. Again, two examples of those are Azium, not SP, and dexamethasone, not SP. All right, so those are the fast-acting ones. These are the slower-acting ones that, again, it's going to take a long time to dissociate off. There are moderately insoluble esters, and they release these glucocorticoids a lot more slowly. These are some of the examples of them. Acetates, diacetates, tebutate. The one that you'll probably recognize, or the ones that I recognize the most, are prednisone acetate, hydrocortisone acetate, methylprednisolone acetate, which is used a lot, called Depomedrol. But again, the difference in these is they're taking this steroid, they're putting an ester on it that's going to take a long time to, it's kind of going to hang in there, and then the soluble part of the glucocorticoid is going to adsorb off slowly. Okay, and then poorly soluble esters, these are some of the examples of that, and the one that I always think about that I've used is triamcinolone. Who's used Vetalog? Okay, great for skin stuff, right, because it hangs around for a while. And again, Depomedrol will be another thing they tend to use in cats because it hangs around a while. The other drug that I wanted to talk about is budesonide, or Endorocort. This is a synthetic corticosteroid, and it's linked to butyraldehyde. One of the issues with this drug is it was made to treat like an inflammatory bowel disease in people because it's supposed to be degraded during the first pass as it goes right through the liver, and therefore it's supposed to have less side effects. That has not been shown to be the case in cats and dogs. I'm telling you about it, at least with dogs in inflammatory bowel disease. We use it sometimes in refractory cases because those animals may not respond really well to some of the drugs that we're using, and sometimes Endorocort just works really well with them. So the idea is it's supposed to be almost a topical for your GI tract, not have a lot of side effects. That has not been shown to be the case in veterinary medicine, but again, it's something that you certainly can use, and it's something that can be a drug that some dogs just tolerate better. All right, lots of different ways. I'm sure all of you are familiar that you can take glucocorticoids, oral, tablets, syrup. You can inject them anywhere. You can have them in ointments. You can have them in sprays. You can have inhalers. derm, when you go, I'm sure you started talking about derm drugs already. They've got every way that you can possibly use glucocorticoids in dermatology because so many of the diseases they see need glucocorticoids. And the other thing that I want to remind you about is there is a ton of glucocorticoid combination medicines out there. And these can be tricky because you can use, and the best example I have is Temerol P has this tiny little bit of prednisolone in it. It's really tiny. And it's made for allergies because the steroids really help with allergies. And I had a dog that actually presented to me with calcinosis cutis from Temerol P. And I thought there was no way that could ever happen. This was a big old bulldog too. And I thought there's no way that could ever happen because there's such a low dose of steroids in there. And some people forget that there's steroids in some of these drugs. So again, just be alerted to the fact that there are combination drugs out there and the steroid side effects can certainly happen with these combination drugs. All right, glucocorticoid rules. This is what I think is the most important part in walk-around knowledge that you need to have. Every dose of glucocorticoids, if you have a different dose, you can have a different action. The doses are described in prednisone doses. And you in your mind, usually what people are doing is they're going from prednisone to dexamethasone because they want to use like a Dex SP and they want to give it IV. And it's a lot cheaper to use Dex SP than Solu-Delta-Cortef, so we're going to have to switch back and forth between prednisone and dexamethasone. So remember that dexamethasone, and I'm writing it right here, is more potent than prednisone. You need to divide your prednisone dose by 8 to 10 to get the dexamethasone dose. So this is how you're going to use your glucocorticoids. We use them as a physiologic replacement. This is going to be primarily to treat hypoadrenocorticism or Addison's disease like we talked about last time. You're going to supplement your mineralocorticoids like your DOCP, and you're also going to give prednisolone at a physiologic dose. It is 0.2 to 0.4 mg per kg, and that's going to be once a day. All right, first dose. Anti-inflammatory dose. These are going to be the dose that you're going to reach for when you are trying to treat an immune disease like bronchitis, like asthma, like skin disease, like if you're an orthopod, like any sort of arthritis where you can't use NSAIDs for whatever reason. And the dose for the prednisolone dose for that is going to be 0.5 to 1 mg per kg. So what's the dexamethasone dose? 0.05 to 0.1 mg per kg, okay? Again, this is walk-around knowledge you need to have, and you will be asked this, I promise you, in clinics like every day. We use these drugs to treat immune-mediated diseases like IMHAs, immune-mediated polyarthropathies, eosinophilic enteritises, immune-mediated thrombocytopenias, inflammatory bowel disease, and all those really disgusting derm diseases. They use them a lot. Okay, this is a picture of a dog. What does this dog have that might be on this slide? It has an IMHA, that's absolutely right. And this dog was actually icteric because it had an IMHA. Does anybody recognize this person? It is. That's when Jared Williams was a student here. Seriously, that's when he was a fourth-year student here. This was one of the cases that he had. Okay, so the dose for this is 2 to 4 mg per kg divided. So you're either going to use a mg per kg twice a day or 2 mg per kg twice a day. Okay, somewhere in that range. Now, there are different clinician opinions about whether going up to 2 mg per kg BID helps. I am one of the people that think it does. There are some people that say you never have to go that high. But anyway, if anyone asks you an or an immune-mediated dose or an immunosuppressive dose, they're going to be looking for this dose. All right, we talked about how glucocorticoids cause lymphopenia and that they destroy lymphocytes. So we can use them to help us with neoplasia. And again, I have a picture of a golden retriever up here because it breaks everybody's heart when they get lymphoma. But the dose here, you absolutely can use steroids. It's part of the CHOP protocol here to treat lymphoma. And we use prednisone at 1 mg per kg once a day. We can use steroids to help us treat hypercalcemia. And because it causes a nice calciuresis. And it's kind of you can't use it. Unfortunately, people use this, then the animals end up having lymphoma, and it's hard for us to find because it killed all the lymphoma cells. But if you have hyperparathyroidism, this is a drug that you could use to help you. And that dose is also 1 mg per kg once a day. You can use glucocorticoids to help you with a low-dose dexamethasone suppression test. This you don't have to memorize because you can look this up in a formulary about how to do endocrine testing. But I put it in here anyway because I'm an endocrinologist and I think it's the most important thing that you know. But this is not walking around knowledge. This is knowledge that people look up. But we use it for low-dose dexamethasone suppression testing. And if we're going to use that, you want to use something that works quickly. So you use DexSP, and in dogs it's 0.01 mg per kg, and in cats it's 0.1 mg per kg IV. And if you know that, when Dr. Bugbee asks you this next semester, he'll just think you're brilliant. All right, so do not forget to divide your prednisone dose by 8 to 10 to get the equivalent dexamethasone dose. A lot of people just use 10 because it's easier. Just a few little things on dosing, things that you need to remember on dosing requirements. So we know that there's an HPA axis. We know that glucocorticoids will suppress that. We also know that using glucocorticoids over a long time period can cause problems. So you can get some side effects from that, basically in the liver. So you want to use the smallest dose over the shortest time period that you can use to fix the problem that you're trying to fix. So for anti-inflammatory properties or to treat inflammation, you're going to want to use the induction dose for 5 to 7 days. For immune-mediated disease, you're going to treat them longer depending on what your protocol is going to be. Again, immune-mediated diseases are where we see a lot of glucocorticoid side effects because we have to treat them for so long. And then for an immune-mediated disease, you're going to want to wean slowly if they're on high doses over that time period. So again, the dosing rule kind of here is that if you have them on chronic therapy, you want to get them on the lowest dose that you can to avoid the side effects. But again, you got to give them enough so it's effective. Yeah.
So you said wean slowly over 6 months. Do you mean like if you're treating for more than 6 months, wean slowly?
No, when we treat an IMHA, and that probably wasn't as clear as it should be, and I apologize, but when we treat an IMHA, we put them on pretty high doses of steroids, and because that disease is so hard to get rid of, we will wean them over 6 months. But if you had a general anti-inflammatory, like let's say you were trying to get them over an acute phase of inflammatory bowel disease, you'd probably wean them over a week or two. But IMHAs are really bad immune-mediated disease, especially IMHAs we wean over like 6 months. So remember that abrupt withdrawal therapy can cause iatrogenic hypoadrenocorticism, so you never want to just stop glucocorticoids because you have suppressed this axis. So you've given a ton of stuff here, you've shut this down, and if you take it away, all of a sudden the adrenal glands don't have time to regenerate. So you can actually cause a iatric hypoadrenocorticism or iatrogenic addisonian. So if you treat them for more than 24 hours using intensive therapy, you want to taper it. Usually what I do is cut the dose in half once a day. If they were on twice a day, do their dose once a day, then cut that in half for once a day, and then every other day. And there are tapering protocols out there that you will learn. The basic thing to remember is you can't just pull them off abruptly. And I'm sorry, I'm going to stop here so that you guys have a 10-minute break. I have tons of time to finish this yesterday, and we'll have some tomorrow. And we'll have some cases to go through tomorrow as well to give you some examples about using these drugs. So, all right, thank you. I'll see you tomorrow.
dog. I think you saw him on your last day of clinics.
Oh, did I really?
He was like the weirdo, like the Pomeranian with hypothyroidism, Cushing's, and diabetes.
How's he doing?
He's doing great, actually. Like everything seems really well controlled. The last time I took him to see Dr. Gross, so like they're really happy with his progress.
Oh, good.
The last time I did like the freestyle Libre on him, and he did really well on it. So I'm gonna take him back for his reach next too.
Oh,
Yeah.
so good. I do remember him. Yeah, those are great cases.
He's very fascinating.
Yeah.
It's like kind of just like sparked my interest, I guess, in endocrinology.
Oh my God, you have to be an endocrinologist now
Like, I
because
can't.
you're dealing. No, you can't. You have to do it. That is so cool. I'm glad he's doing well. I remember him now that he said that, and I thought, oh, what a cool case. And then I was like, oh, and I won't be here, and I won't get to follow up on it. But I'm glad he's doing well.
Yeah, I did have a quick question.
Yeah.
Relating to like the fatty liver, we talked about like how there's like fat deposits.
Yeah.
I know we learned in Gen Path, like there's also like hepatic lipidosis where it's like deposits in the liver. That's like a reversible change. Is that actually reversible in Cushing?
Yes, it
Okay.
is. If you get their cortisol under control, you can make a big difference in controlling the amount of stuff that goes in there. So you will notice over time their liver size will decrease
Right.
as you treat their Cushing's disease. So yeah.
Cool. But does the muscle waste thing, like does that muscle kind of
It
come
comes back too.
Okay.
So within 6 months, these guys oftentimes, well, even less than that, like 4 months, they'll
Okay.
regain their muscles, and they'll also like their liver will become normal. And if you have a dog that's on like a lot of steroids and they get the atrophy of the head muscles, give them like a couple of months being off the steroids, and that will all come back. So it's all reversible.
Awesome. Okay, I was just curious. 'Cause I was thinking about that. I was like, wait a minute, is that like the same idea or not? But that's really
So what kind of insulin do you have your dog on? I can't remember what we did. What's he on now?
Inulin N.
Oh, he is?
Yeah.
Good. That's
And-
good. It's saving you some money.
Is it? I feel like it's so expensive.
Oh, it's
not Novolin, right?
no, but you know you can get that. You can get the generics.
Is it acceptable? Because I talked to my vet who like first diagnosed him with diabetes, and she warned me don't suddenly switch him from Novolin to Inulin or Inulin to Novolin.
You can try it.
Okay.
Most people have had pretty good luck with it.
Okay.
So it's pretty equivalent because the Humulin, yeah, you're right, that one's really expensive.
Yeah.
So I mean, like I would wait until they're like totally under control before I tried changing anything, and maybe
It like works for him, so like I feel
I
like with all his
wouldn't
complications,
mess
I'm
with
just
it.
like,
Oh, I'm so sorry.
thank you, Dr. Ward.
Yeah, it's good to see you.
So they know what they're setting up, and so then all I'll have to set up is the
Did
demos.
something explode this morning?
I almost left my husband this morning, so yeah.
Oh, Jesus Christ.
And-
Okay.
And yeah, I almost had a self-harm this morning, so I am just
You
having
need
a...
me to do this lecture?
I think I got this lecture. I had to send Janet a not very nice, just a crap, she was trying to get me to figure out where the white bin was to put the sample things in, and I'd seen if it was in the lab, if I could ask Chris to bring it down, and I was like, Janet, I don't have time for this morning, and I was like, I think it's in our lab.
Okay, I will be in there. I will be in there a little bit before 1
Yeah.
to provide backup. I'll just be blunt. Is there anything I can do, small or large?
No, I think we're good. I think we're good. Like I said, and I made it very, very, very clear that we needed ruminant only samples, and I put big words, no equine.